Well, very interesting is going to be the combo of blinaino sequentially, both relapse refractory situation, but as the frontline situation, we integrate that into chemotherapy. I think those trials are going to be very fascinating. Also fascinating is going to be in the Ph positive ALL space, where you have potentially the chance in the elderly patient population to get away from chemotherapy completely. In just a previous little bit induction with steroids and vincristine, I mean, there's been great data by Robin Foer showing that when you add dasatinib, that you have 95% response rate in elderly patients. So you already have great disease control, and it'd be fascinating to see if you then integrate blinatumomab or inotuzumab, or both, in that sequence, that you may build a strategy that is completely chemo-free. So I think that is also something that might involve, and then we can use that situation perhaps to extract something and take that information into the younger patient population and work with that. Because if we can show the elder population that we can have long-term control of the disease with that non-genotoxic therapy, why not offering that to someone who's 25 and get rid of transplantation with all the side effects? So I think there's much to be looked at, a lot of visions, many questions to be answered. I mean, thankfully, ALL is a rare disease, but we may have really some great tools to really make a big difference for these patients. But with more information and more ideas of individual signaling pathways that might be disturbed, and there are some case reports where you just add a tyrosine kinase inhibitor, not targeting Ph positivity, that show great single agent activity. So this could be another wave that you have very personalized medicine, that you have a complete picture of the ALL genomics, transgenomics, and proteomics, and gather all the information and build that in with the immunological approaches, and have a very personalized, tailored medicine approach. So this could be something that also could be evolved down the road. Because currently we're using just chemo, which is a pump gun, blasts everything away. But if we combine it with more personalized approaches, genomics, with the current immunological approaches come together here, that'd be also a great avenue that we can look at down the road. I mean, we have such amazing information, genetics, what it means, targetable tool genetics, very lot of emerging data coming along through the field. So the challenge is to really establish what are great single agents or combination agents on that level that we can use. How to get the data in time to make decisions quick and fast, available for everyone. And then to take that information, those new treatment approaches with what we just spoke about, blinatumomab, inotuzumab, and CARs, all the CARs that are available, which is sort of, and then with the old agents that we know. Well, we know which agents we want to get rid of, which are the genotoxic ones, like the anthracyclines, which are terrible for patients. They have shown in the pediatric long-term setting. They treat, they get a lot of problems, cardiovascular problems, secondary malignancies, and so get rid of all the nasty stuff, and then we reduce ALL therapy to non-genotoxic drugs, which includes asparaginase, methotrexate, vincristine, steroids. We'd like to keep those and combine them with the genetic approaches, with all the immunotherapy approaches. But it could be very kind of a backbone that we have, and then we plug in the genetics information into the patients. So we develop a backbone that is based on common strategies, so there will be immunological strategies and the non-genotoxic ones. And then we have the genetic information that we just add to the mix, but that's very personalized. But how that will evolve, it's a great story to look at. New chapter, new book.